Hi, good evening, everybody. We are here again for our usual Wednesday webinar, and I will be the speaker for tonight's webinar, so I don't need to introduce anyone. For those of you that who doesn't know me, I'm Gianluca Rovesti, and I'm a veteran surgeon working in Italy. And just a few technical details. This is the after last, so we will have one more webinar next week that will be held in Italian. This is the last webinar that we are giving in English, and the next one will be also the last one for this year, of course. We are planning a new program for next year, and as usual, you can keep updated on our website www.mayora.eu. Okay, and this webinar, the topic of this webinar is shoulder subluxation and luxation. As usual, we will have 2 commercial breaks during the webinar. We will have 2 breaks during the webinar, but I guarantee you that they will be less than 2 minutes. So I will be back very soon, and you will have the option at the end of the lecture to make your questions, and to do that, you should use the text chat that you have on the right column on your screen. So you can type your question, and I will be glad to answer to every question. Okay? So just start with the lecture. Shoulder subluxation and luxation. So we will deal with different aspects of this disease that, of course, sometimes is a little bit demanding about the exact comprehension of the features of the disease itself, diagnosis, and the main thing is that we have different patient cohorts, meaning different kind of patient, different categories of patient that I will try to go deeper in a minute. So the first problem is defining exactly what we are talking about when we talk about shoulder subluxation. There is no widely accepted definition of subluxation, meaning that is the same term as instability, is the same term as laxity. Is not very clear what we are referring to with this term, and this is something that will impact on the way we can plan the treatment of the disease. And I will try to give you my personal approach to this. So we need more or less a final diagnosis as usual in order to be able to plan what is the scheduled treatment. Do we have surgical techniques for the stabilization of the subluxation? Can we use the classical ways like bicipital tendon transposition, or is the bicipital tendon a cause or an effect in this disease? So the invasivity, we will evaluate also invasivity versus effectiveness of the procedure and some problems in performing, in giving a correct postoperative care, okay? So the first group that we are dealing with is the group of dogs, small breed dogs. They can be puppies or young adults usually, and they don't have usually a previous history of trauma. The classical clinical presentation is like this. Sometimes is even difficult to understand exactly what the owner is referring to. You should take your time. As you can see now, just a quick time of not weight bearing like this. So you should take your time and for a correct observation. Usually not very dramatic lameness, but this is the classical young dog, small breed, and of course we have also, this is the classical patient that is usually treated with anti-inflammatory drugs, okay? Let's start with that and then we will see. Okay, this can be an approach, of course, but when this situation will progress, we can have a more severe presentation like this. So this is a 4th degree lameness. And this was the end stage of a clinical initial presentation like the one before. So same kind of patient with the same more or less obscure presentation. And in most of these cases, if we just take standard X-rays, we don't see that much. So this is not the kind of situation where we can, since the first X-ray, understand completely what is the origin of the disease. Can we check clinically? Yeah, of course. For example, the abduction test. As you can see, I put my thumb over the spine of the scapula and I'm abducting this limb, and I can appreciate that the abduction that I can achieve is more than 45-50 degrees. That is, generally speaking, considered more or less the physiological abduction angle. I think that this evaluation is very personal, is very dependent on how you perform the test. So my suggestion would be simply perform this test in every normal patient you are performing an orthopedic examination. Just because this is the only way that you have to have your personal feeling on how about it should be. So if I perform on a routine basis this kind of test, and when I palpate, when I examine the patient that has a medial articular laxity, like in this case, I will have a perception, I will have the feeling that the abduction is not completely normal. This doesn't represent the final diagnosis, but is an issue, is just a sign that we are dealing with that kind of potential situation. Of course, right now we have many diagnostics tools available, and this is good, of course. Of course, we need also the correct interpretation. Like in this case, you can see on the medial side here, this changing color of the capsular ligament, and the bone itself can be an index of something going wrong. It's not the only way to do that. We can use also more classical ways. In some patients, we can elicit this kind of subluxation. You can see here. So if you look here, okay, this area, this shadow here on the X-ray is just the sign of this radiolucent tube that we use to push on specific anatomical regions in order to appreciate some kind of instability, or if we have to elicit some specific responses. Okay, this is again something that you should develop yourself, because this can be tricky, and some degree of artifacts can be present simply because you change the angle of the joint, or you abduct or adduct the joint in a different way. So this is something that, or either you should refer to a radiologist that you trust in, or if you want to develop this skill yourself, you should be confident in performing in quite a standard and consistent way. Otherwise, the risk is to have artifacts that you will take as diagnosis. As usual, I think this is always the case, okay? This is not specific issue. This is true, in my experience at least, for all the diseases that we are dealing with. Okay, of course, in this case, not a major issue, okay? In this case, the diagnosis is really straightforward. Please note that we can make some kind of thoughts about this kind of picture. The first one is that even without more sophisticated diagnostic tools like CT or something like that, you can already see that this is very likely a dysplastic luxation, meaning if you look to the medial border of the glenoid, we cannot see any medial border of the glenoid, okay? So this is very likely a dysplastic luxation, meaning that the glenoid is dysplastic and the humeral head, this is a young dog, as you can see from the physis here. So the humeral head will luxate simply because it doesn't have a place to stay with, okay? And in most cases, we have to balance the decision about a surgical approach with the evaluation of the clinical situation. Why? Because some of those patients are clinically with a very subtle lameness, not very severe lameness. So if I have a patient that has this kind of radiographic picture and it has a subtle symptomology, of course, I won't push too much for surgery, okay? So always balance, don't schedule the surgery because you receive these pictures on your computer by email, okay? Clinical examination is the first step. And the first rule in orthopedics is you can never examine an X-ray, okay? You should examine the patient. We have another kind of situation with a severe lameness, quite a severe lameness, but when you take the X-ray and you, as usual for us, for example, this is a patient, we took this X-ray simply to examine the left shoulder, and I was convinced by the clinical examination and by palpation that this patient had a shoulder luxation, and then when they got back to me with the X-ray, they told me no luxation at all, no luxation at all. And I was not convinced because I clearly felt the luxation during the movement. But I just realized that this picture, this X-rays was performed with the extended limb, okay, extended limb. And sometimes you have the luxation that will happen just on flexion, same patient with the flexion. So don't trust the first picture, okay? You should test both extension and flexion. And of course, if you perform the radiographic examination under general anesthesia, of course, you can take the sagittal projection and the comparative one that in most cases will clarify the situation and the disease. But this is just to say that trust your clinical feeling. If you feel that there is a luxation, don't trust the radiologist. There is something that you should examine in a deeper way, okay? So, what happens in those patients? In most cases, not all the cases, we are not dealing so far with traumatic, that is another group, okay? We are dealing with this kind of patient. These are all, most of them, dysplastic or developmental diseases, okay? In this case, in my experience, there is a negative prognosis for salvage of the physiological joint, and in most of these cases they will end up with shoulder arthroplasty. Shoulder arthroplasty is more or less conceptually the same thing as arthroplasty for hip necrosis, hip severe dysplasia, or aseptic necrosis in small breed dogs. So it's more or less the same thing. Just have a quick overview of the procedure. So the approach is performed by osteotomy of the scapular spine, like this, because we can elevate the biceps, the deltoid insertion on the spine. And in this case, we perform a complete glenoid ostectomy, starting from the cranial part of the scapular glenoid to the caudal one, and we did the same for the humeral head. Okay, so this is quite, let's say, the straightforward procedure. Of course, as every kind of procedure has its own rules, but not very difficult one. The problem with that is that doing that, cutting up to the cranial part of the glenoid, actually we are cutting out also the bicipital insertion. okay? And this, of course, can cause a bicipital retraction. That means that the biceps won't act actually as a flexor of the elbow and extensor of the shoulder, and so we should take this into account. If we think for any reason that to preserve the biceps is important, we can use a different approach, like in this case. For example, in this case, we perform a caudal glenoid ostectomy, like this, in this area, and ostectomy of the humeral head, okay? In this case, the reason why we performed this kind of approach was due to the fact that I consider it in this dog important to preserve the biceps function, okay? So in this case, I didn't want to cut the insertion of the biceps tendon out. And this was the reason why I started 1/4 of the glenoid extension caudally. In this way, you can preserve the insertion of the biceps over here without cutting it out. And this is the sagittal projection. In this case, instead of just using one circular wire for the synthesis of the spine of the scapula, we use a different technique, quite common one, that is a K-wire with a tension band. Okay, this is quite straightforward technique, but it's a little bit tricky simply because the spine is very thin, so you don't have that much bone stock to trust in, and so careful for that. One specific point about the cat. In the cat, you should deal not just with the acromion, but also with the metacromion, and you should take this into account when you perform the osteotomy and then afterward when you perform the synthesis, okay? What is the prognosis of this kind of treatment? Usually good, but in most cases we have a residual mechanical lameness. Residual mechanical lameness means that those dog has good walking, they don't have pain, but as you can see, they are a little bit limping simply because, of course, the mechanical support of the shoulder is not physiological one. But if you consider that this at the beginning of treatment was a 4th-degree lameness, 4th degree, of course, the recovery was quite nice, okay? One important point is tell the owners that this is usually requiring quite a long recovery time, okay? They shouldn't expect that the next day the dog is working normally. It will take months. So just make them aware that this is quite a long recovery time procedure, okay? So we have now a commercial break. I will be back in a couple of minutes, okay? Okay, as promised, quite a short break, and now we can keep going with that. Then we have a different cohort of patients, a different group of patients, different presentation, and is the group of very active or field trial dogs, meaning those dogs that are usually medium-sized dogs, of course, hunting dogs or trial dogs, etc. They are not very heavy one, or at least even if they are big dogs, they are very athletic dog, but they have this kind of obscure kind of lameness. We can rule out most of the other disease of the front limb, meaning FCP, OCD, etc. Usually they are middle-aged, meaning not very young, 3, 4, 5 dog with some kind of specific field activity, hunting, as we said, and all these working dogs that are actively using the limbs. In most of these dogs, we have, of course, many different diagnostics tools, but one of the things that I like to do in these dogs is to check for, when I perform a radiographic examination, I always take a sample of synovial fluid from shoulders, okay? And then I like to palpate thoroughly the shoulder. And when I have some kind of doubt, this is a fluoroscopic picture, please check the click into the joint, okay? And usually, if you thoroughly explore the joint, you can see from the picture that we have a point where we can palpate this kind of click, okay? And we have this, I define it kind of craniomedial instability. Craniomedial instability. In those patients, what I don't like very much is that in most of these cases, what is suggested from some surgeons is arthroscopic examination of the shoulder. I agree completely with that. Arthroscopic examination, I agree completely. But biceps tenotomy, I completely disagree with biceps tenotomy. Of course, I have examples where I agree with biceps tenotomy. Why? Because if you find a bicep tendon that is attached for just a few fibers and is very painful just because it's very few fibers of attachment, I agree that this is a good indication for biceps tenotomy. Why? Because we don't have a very effective way to reattach the biceps tendon, okay? But I don't like the sentence like I performed the shoulder arthroscopy, I didn't see anything significant, so I cut the bicep tendon. I cannot accept this. This is not ethical. This is not technically a good approach, I think. In most of these dogs, we have an instability, okay? Instability means there is an area of this shoulder, instead of performing a very smooth range of motion, we can palpate this click, okay? We start in a smooth way and then click. This is the patient I'm referring to. In those cases, this is an arthroscopy, and if you see, this is the subscapularis tendon. As you can see, we have a mild, not severe synovitis, mild synovitis, but this tendon is very lax, and the capsule, even though it's difficult to evaluate. In those cases, in this kind of patient, I like to perform radiofrequency shrinking. Look to this tip. If you look to the tip of this, there is like shrinking, like sucking the tissue, okay? And at the end, look to this bicipital tendon, this one. I think this would be very bad to cut a tendon like that. Also because the bicipital tendon is one of the most important elements for shoulder stabilization. If you are not sure that it is the responsible, the guilty for the disease, don't cut it. Why? Because it will get worse afterward, okay? So just to say, we don't need to say, I was in and I needed to do something. If you don't understand exactly what to do, don't do anything. What is the Hippocrates' word? The Hippocrates' word is at least not doing worse, at least. Okay, so this is what we should refer to. The important thing in those patients is that the fibers, the collagen fibers that are shrinked are very lax for at least 2 weeks after procedure. So we need to protect this shoulder. How? It is not always easy. The reason why we need to protect it is because if you leave the shoulder free, even if the dog is confined, they are so lax that it can be eventually even worse than before, because they will be longer if loaded. So we need to protect the shoulder. Bandages, of course, we can consider bandages, but with bandages, of course, the bandage is not very handy, is not easy for the owner to manage the bandage, and all the problems linked to bandage. They move, they can cause compressions, etc. So what I like to do is to use bodices. I show you an example. This management is not always easy, either for the owner and for the dog, okay? So this means that you should anticipate to the owner what are you expecting from him beforehand, just to avoid that after the procedure he won't be able to follow you in this management, okay? The other limit that should be anticipated is the result is unpredictable. Unpredictable means I have very nice results and I have bad results, okay? And based on this, I can suggest the owner what will be the next step based on the result, the previous result, okay? Good. What is the bodice that I like to use? This one. So it's a specific bodice thought for this. There are different sizes. So the sound limb is out of the bodice because this will be the weight-bearing limb afterward in the post-operative period is 3 weeks, okay? 3 weeks. And thanks to this belt here, we can set how to stabilize the limb, meaning if I will hold this belt very tighten, the limb will be more or less statically bandaged or immobilized, okay? If I leave it a little bit looser, the shoulder and the elbow will be able to move, even though not weight bearing. And this will be good because in this way, of course, we will have physio starting during the protection time. And this is from the side. So it is very handy simply because with this opening here that is on the dorsal part of the bodies here, the owner can open here and make physio couple of times per day here, and in about 30 seconds he can take the bodies out off and to put the bodies on again in 1 minute. So we don't have to waste time in doing bandages that of course are not very handy to manage. Okay, so this was the second group of patients. That kind of subluxation or instability or laxity, what is the perspective in those cases that don't get better? Medial arthroscopically assisted stabilization of the shoulder, but this is not, I'm not dealing with that this evening simply because it's a very specific treatment and it will take the whole hour alone. Okay, so we have a third group that is the trauma group. So it doesn't have to be a big or small patient, a young or old one, because trauma is trauma. Okay, so we don't have a specific reference for this group. Can we think about a conservative treatment in this kind of patient? Yes, we can. Under these circumstances, if we have other lesions, for example, we can decide that we have other fractures. We want to protect this luxation, but we want to treat before the fractures. When the instability is minor, so we feel the instability, but it's not luxation so far, or if we think that once we reduce the luxation, it is stable enough to think to wait and see. Okay, in this case, of course, ultrasound is mandatory in the next days for correct evaluation of the involved anatomical structures. If we know by ultrasound, if we have extensive damage to soft tissues, of course, we can understand what can be the perspective on this patient, okay? And at 2-3 weeks, we can recheck the patient for evaluation of the surgical option. If the luxation will stay stable, of course, we can wait. If the luxation will relapse or there is some kind of negative clinical evolution, we should go for a surgical stabilization. During this waiting time, evaluation time, again, bodies, okay? Very simple, handy, straightforward. Every owner in the world can learn how to manage this, okay? Then, of course, we have the case of the traumatic luxations. Okay, in this case, we have a few key points. Medial luxation are more common statistically than lateral luxation. We have many surgical techniques described, but if you look to those techniques that you can find easily in the literature, you can see that 95% of them are just referring to a lateral suture techniques. In my experience, lateral suture techniques is quite effective for medial luxation, not always for lateral luxation. And for lateral luxation, I prefer a different technique that I will show you in a minute. And this different technique, that is a medial cross suture technique for lateral luxation, is the one described by Dr. Slocum. Okay, so for medial luxation, that is of course always this kind of evaluation, but from this we already see that there is, when I see to lateral x-rays of the thorax, simply because the dog was hit by a car, I can just have a look here, and from this picture I can tell you that there is a shoulder luxation. Okay, I don't need very fancy, sophisticated projection. From this picture, I can tell you there is a shoulder luxation, or fracture, or both. Of course, we can check more in a detailed way. And in small patients like this one with medial luxation, I think that it's quite easy, let's say, to use lateral sutures, and it's quite effective. So we can perform this kind of tunneling at the base of the scapular spine here. Just careful for the subscapularis nerve. Okay, just careful for that. But you can stay a little bit more proximal. Another tunneling at the base of the humeral head, like this, and then with just nylon suture, nylon line, and a crimp like this. This is usually quite a simple technique. You can require, not always, but sometimes you can require also the osteotomy of the spine, or there is a different approach for exposing this area, that is by holding the shoulder flexed, was the approach described by Kelly many years ago, that is very effective for this. And in this case, we can have nice results with quite a simple way to perform it. The only tricky part is that if, like in this case, you perform the whole lateral-medial, this can be difficult for retrieving the suture. Okay, so if you use this technique, an oblique tunnel, bone tunnel, is easier, and it will allow us to retrieve the suture in as easier way. But for medial luxation, this is quite simple technique and straightforward. Okay, we have a second commercial break. I'll be back in a couple of minutes. Okay, here again with the last part of the lecture about lateral luxation. For lateral luxation, we have mainly two different approaches that are cranial lateral sutures or medial crossed medial sutures. Okay, we cruciate lateral sutures. I think this is the easiest procedure. So the procedure starts by performing this tunneling that is at the base of the glenoid, okay, through the scapular neck. The only difficult point is this one, retrieving the suture with a curved mosquito. And the reason why you should be careful for this procedure in this phase is because on the medial side, we have the brachial plexus nerves. So this means that we should careful about that and then perform this tunneling at the base of the humeral head here, same direction from cranial to caudomedial, okay? And then we can reduce the luxation and make a knot, or even better, using a crimp, just to avoid the bulging of the knot. Okay, this is an effective technique, quite effective, but in about 50% of the cases, so the cross is like this, okay? Is completely lateral, more or less, like in the small dogs, but of course with a more extensive capability of holding the lateral wall of the joint. In about 50% of the patients, in my experience, this is not enough. And the problem is due to the fact that mostly for the caudal part, this suture is not capable to hold enough the humeral head. So by performing a rotation in pronation of the shoulder, the luxation will recur, and this suture is not capable to hold it. And this is the reason why in some specific cases I prefer the next technique that I'm going to show you. What about bicipital tendon transposition? It is a well-described technique. I used it in the past mostly for medial luxations, but right now my question is, does it work? In my experience, in most cases, the simple transposition of the bicipital tendon is not strong enough to hold the joint in correct positioning. So I would say the technique itself is not a dramatic one, is not too demanding, but the problem is that the approach is quite aggressive, and if you have to perform the caudomedial transposition of the bicipital tendon, you're required to detach the pectoral muscle insertion. So I don't feel that the final result will justify this aggressive approach. In my experience, transposition of the bicipital tendon is something that I'm not more using in my experience, okay? But we have another option for very unstable luxation, that is a crucial medial sutures. I will show you this case. This is a mongrel, very active dog mongrel, but like mongrel with border collie kind of dog, so very active dog with lateral luxation of the left shoulder because it was hit by a car. And this was the initial presentation. We reduced the luxation. Apparently, it was successful. So we performed a shoulder bandage, a shoulder sling, but after 3 days, we had this kind of situation. And at that point, we should consider the two options. We will get back to this topic because I already see a question about shoulder arthrodesis. If I can, of course, I will try to avoid arthrodesis. And in this situation, what I'm suggesting to the owner is to get inside and to check for anatomical condition of the cartilage of the joint surfaces. But if I have a chance, I will prefer to get back to a more physiological condition, okay? So this was pre-op examination. I have some doubt about the borders of the glenoid, if there was some kind of comminutor fracture that can impact, because I was not able to understand completely this area of the glenoid. In this situation, these cases, I find CT examination very helpful, simply because with CT examination, we can check for in detail the anatomical structure, so we can understand exactly if we have some kind of bone damage, bone fracture, even if it's a comminuted one or not completely visible one. Okay, in this kind of situation, with a very unstable lateral luxation, and with a correct joint surface, I mean joint cartilage, I prefer to use this Cruciate medial sutures technique that is like this. We have the deltoid insertion on the acromial part of the scapula, of course. So I start performing this all with a K-wire in order to have, before performing the osteotomy, in order to have a correct guide afterward for the K-wire for synthesis after the procedure. Okay, so I already have this guide made before starting. And then we can perform with the osteotomy. The most common mistake in my experience that we tend to do was to perform a too small osteotomy. Too small means that we have the fear usually to damage too much this part of insertion of the spine, and we stay to the tip of the spine. And instead, you should understand exactly where is the base of the spine and cut to the base. Of course, be careful for the subscapularis nerve. This is the only way that you should be aware of. And then we can reverse the the deltoid muscle completely, and here we can see the lateral part with the infrascapular muscle and teres minor tendon as well. Okay. At this point, the rationale of the procedure is to have this kind of suture. So the X part of the suture is lateral, but we have these two passages that are on the medial side. The dot lines are the inner sutures, okay? And this passage here specifically is the most important one because it's one that will hold very securely the joint in place. Okay, so the problem is how to get this passage done. Okay, and for this I use the fluoroscopy to help me during this. It is possible to do that, but of course this is a great help. So I start with the cranial hole here at the base, more proximal than the glenoid, and then I perform the caudal hole as well, and this passage that is at the base of the humeral head, here at the base, in the center, let's say more or less in the center of rotation, okay, more or less. Of course, the best you can do, okay? And then we need to retrieve the suture. How can I retrieve the suture here? Okay, we will use a simple circlage wire inserted through the hole. The circlage metallic wire is visible with fluoroscopy, and I can feel it with the tip of the mosquito forceps. Okay, so I can go on the medial side of the glenoid with the mosquito forceps and retrieve the circlage wire, double circlage wire that I can retrieve as a guide wire. What does it mean? It means this. I retrieve the circlage wire here from the medial side, and now I'm using it, getting back with the suture. This is a kind of fiber wire suture, okay, that kind of family of very strong sutures, and I'm retrieving it from the cranial hole in the glenoid part, okay? So I have this first part retrieved here. And then I can do the same on the caudal hole. So I again pass the circlage wire from the caudal hole, and this time I will retrieve one end, the caudal end of the suture through the caudal hole on the glenoid side. So now I have the suture that is, both ends of the suture are on the lateral side of the scapula, but the passage is on the medial side. So very secure passage. Now I need to pass the cranial end of the suture underneath the infrascapularis tendon and muscle, because I want to go on the caudal part of the humeral head, okay? And once I'm there, I will use again the technique of the circlage wire through the hole into the base of the humeral head, to get out from the caudal part, and I will again use the circlage wire to bring this end of the suture, that is the cranial, exiting the cranial, or here on the glenoid side, passing underneath the infrascapularis muscle and underneath the humeral head and outside from the lateral side here. Okay, this is the crossing. I will show again the drawing afterward to debrief this procedure. Once I have this end of the suture on the lateral side of the humerus, of course the procedure is straightforward, because I just need to perform this kind of stabilization of knotting. You can do either way, performing knots or with a crimp, whatever you like, on the lateral side. And this knot will join the caudal part of exiting from the caudal, all of the glenoid side with this area that is exiting from the humerus. Okay. At the end of the procedure, of course, we are reattaching the deltoid with the by reattaching the scapular spine like this with a K-wire and a tension band. So again, this was the first passage. I have the two extremities. This cranial extremities from the extremity from the glenoid, I will pass here, and by a circlage wire, I will retrieve it from the hole in the humerus. And once I have on the lateral side of the humerus, I will make my knot or my crimp over the lateral side here. So this is the overall rationale of the procedure. And this, of course, is the final stabilization of the osteotomy of the spine. Okay? And this is how it looks like on the lateral projection. So, just clinical and radiographic rechecks. Usually, I just perform mediolateral projection rechecks with the awake patient, because this kind of positioning is quite comfortable for the patient. So if I see that everything is fine, I don't need general anesthesia in order to perform this recheck. At the beginning, of course, the dog is quite cautious, and you should have the cooperation of the patient. This is after a couple of weeks from the surgery, when we remove the bodies and we start letting the dog to use the dog progressively, of course. And after a couple of months, more or less, it should be more or less, let's say, normal weight bearing, if everything goes nicely, of course. Okay, but this technique, in my experience, is very strong and effective one. Okay, so so for questions of the next days, as usually, you can write me for next question. But right now, after the commercial break, we will have question time. Okay, see you in a couple of minutes. Okay, fine. So back to question time. Okay, you can see here our website where you can find the list of lectures. Next week, we will have a lecture from Gianluca Nocco about radiolucent external fixation of radius and ulna fractures in toy breeds. Okay, you can start with a question from Simone. By Simone. For this moment, it's not a question, it's a comment. I have excellent results with shoulder arthrodesis. Okay, shoulder arthrodesis, I didn't want to talk about that because shoulder arthrodesis is a very big issue. So it was not 1 hour topic, let's say. I use shoulder arthrodesis in very, very specific situations, never, ever as a first attempt. And in my experience, I have a very limited experience, okay, of shoulder arthrodesis, very limited. But you can check, for example, the paper that was published by Fitzpatrick about 14 cases of shoulder arthrodesis, and they had quite a large percentage of very disastrous complications. So arthrodesis, in my understanding of managing this problem, is the last option when I don't have any other option. Is much more technically demanding. The use of implants require a very skilled surgeon because simply the way you have to bend the plate and adapt it for correct physiological positioning, it's more demanding. So as usual, I completely agree with you that the more you know, the more you can decide what is the best indication for your patient. So if you feel comfortable with that technique, with arthrodesis, I mean, I would say, okay, I completely agree. I never use shoulder arthrodesis as a first option. You sometimes use excision arthroplasty of the shoulder joint if reconstruction of the joint is impossible. Christoph. Yeah, of course, as I show you during the lecture, in small dogs. For large dogs, I think that if the reconstruction is not feasible, I can use either way. I have a few cases where we had a not reconstructible fracture of the shoulder, and we just use conservative management, waiting for spontaneous healing. And in a couple of them, usually multi-trauma patient, we have fracture of the homolateral femur, homolateral humerus, contralateral femur, something like that, okay? So we focused more on other fractures, managing in a conservative way the joint fracture of the shoulder. And in a couple of them, we had quite nice result. What I wouldn't do is excision arthroplasty of the shoulder in a big dog. In a big dog, I agree with Simone that in that case, I would go, more likely, I would go for shoulder arthrodesis in that case, okay? Because I think that is the same, more or less, principle as hip arthroplasty. It works nicely in very small dogs and progressively worse in bigger dogs. So the fibrous tissue that we rely on for connecting the joint is good if the load is limited. If you look to the paper that was recently published by okay, the French guy, I sorry, in this moment I don't remember his name, okay, about the shoulder arthroplasty in small dogs. Their study ruggedly, okay, the name is ruggedly. Their study confirmed that the shoulder arthroplasty requires a long recovery time. So in small dogs, I don't have experience in large dog arthroplasty, shoulder arthroplasty in large dog, but in the same way, I don't like to perform hip arthroplasty in large dogs. In the same way, I don't like to perform shoulder arthroplasty in large dogs. Okay, Crystal, you're welcome. You're welcome. Okay, just 10 seconds more, just in case there are more questions coming. The drawing of the passages, if you will check since the lecture will be recorded, has been recorded, and it will be uploaded on YouTube. Of course, you can check again on the kind of passages that are required for this kind of suture. There is one more question coming from Emir. Okay, Emir, okay. Bye, Emir. Joachim, what do you think about the use of bone anchors? Okay, bone anchors, in my experience, can be absolutely considered for the humeral side. In my experience, the scapular side, you don't have bone stock strong enough, thick enough, large enough to accommodate for a secure holding for bone anchor. So I would say good for the humerus side. I wouldn't use, I use in the past for the scapular side, but I always experience some kind of problem. So on the scapular side is not my recommendation, okay? You don't have bone stock enough simply to hold them. Joachim. So I hope to answer your question. Okay, good. If you don't have any more questions, we can end the webinar. I thank you very much for attending the webinar. Next week we will have the last webinar of the year, and of course we will give season greetings, because we are close to all the holidays period, etc., Christmas holidays, etc. So see you for greetings next week, and take care in this difficult time for all the pandemia team, etc. Okay, see you. Bye bye.